Good morning, everyone. I'm really pleased to be with you today, and I really appreciate and honor the recognition this program has received at this meeting. It's a joint effort that's organized by the Camden Coalition, Primary Care Progress, and the Association of American Medical Colleges. And that's not a partnership that one might have organized, expected to see come together, because we don't always see eye to eye on every issue. And I think that's a theme that's come up throughout the day, that as a part of these efforts, you're working with groups that maybe you don't always collaborate together, but there is some common ground that can be found that can lead to great change and transformation. And this one is focused on getting students engaged in hotspotting. And it's really focused on finding those patients who are the super utilizers, the frequent flyers, the patients that are deemed non-compliant, and figuring out new ways to care for them that will lead to better population health and improved health outcomes and greater health equity, and then the golden goose, or the golden egg, of lower cost at the same time. This is the cost breakdown of hospitalization utilization in the Camden community. This is something that Jeff Brenner was able to put together by pooling all of the billing data for I think it was 3 hospitals in Camden that serve population there. And that's really the 1 to 20% of the population that drives the total, almost all of the costs in this community. 30% of hospital receipts represent 1% of the patients in that community. 80% of the hospital receipts account for 13%. And 90% of the hospital receipts are billed to just 20% of patients in Camden. So if you're really looking to lower cost in a community, knowing who these patients are is a way that you can target your resources. And then what we're going to learn through, and I'm going to demonstrate today, is that there are interventions that can help these patients become compliant, because they want to be engaged in their care. They don't want to be coming back to the hospital in the emergency room over and over again for care, but they don't have the resources, or sometimes the knowledge about how to access those resources, or simple things like how to use a calendar to keep track of appointments can be some of the smaller interventions that can have a profound impact on these patients' lives. And what's really happening today is we move from a fee-for-service, where as a patient comes back in a fee-for-service model for a readmission, you get to make more money. And if they come back again, then you will bill for more services, because what's common among a lot of these patients is they actually do have health insurance. In Camden, the patients that were driving up their costs are mostly dual eligible Medicare, Medicaid, and despite having access to insurance, are still unable to get care in the right place at the right time. Can I provide a different level of intervention for them that will connect them with housing? Because if you're going to have to control your intake of sodium, and you're dependent upon food shelters for your food, you're probably not going to be able to do a very good job of controlling your asthma and your diabetes intake. Or as a patient that one of our hotspotting participants found out about, who was living at home, did have a home, but wasn't able to get out and purchase food, lived in a food desert and wasn't able to have the transportation even get to a grocery store, was dependent upon someone bringing him potato chips. And that was his main source of food. And that's not very healthy for anyone, much less someone who has congestive heart failure. So creating new resources and connecting that patient with Meals on Wheels was the intervention that now happened because of participating in a program like hotspotting. And we're really thinking, and we've talked a lot today already about the expanding scope of what people are thinking of healthcare. It's not just what happens in the 4 walls of a doctor's office or a hospital. It's now thinking about maybe it makes sense to pay for a vacuum cleaner for an asthma patient, or for a healthcare system to call and be an advocate and champion for a roach-infested building. And there's an ACO in New York that had patients that were living in a building without a working elevator who couldn't climb up and down the flights of stairs to get to their doctor's appointments. So they are now using the medical legal partnership, pressuring the housing communities to provide high quality and standards of housing. These things just weren't happening at this kind of level before. And meetings like this, where we were really focusing on social determinants of health, is a new way of thinking that's just growing. So with this model, it really is a long process and not just a simple, you find them at the hospital and you talk to them and you're done. It really starts with triage, finding those patients, And it can be through mining your billing data to identify them, or setting up alerts at your hospital when a patient presents in the emergency department to let everyone know, hey, this patient has been here 3 times already in the past 6 months. And making sure that a community health worker or a health coach or a social worker or someone on the care team drops by to talk with that patient and engage in a bedside chat, not to say, here are all the things I can do for you, but to really find out, what are your needs? What is it that you are concerned about, and what are you going to face when you're discharged from this hospital? And are there things that we can do to help you? And beginning the initial care planning. This is actually a patient list that it brings tears to my eyes almost every time I look at it, of the things that he is searching for and dealing with on his own after being discharged. And it's finding the documentation and sometimes what these community health workers do will actually go to the DMV and stand in line and help patients figure out how to get their documentation, which is an essential part of being able to find housing and getting access to some of the resources that they're entitled to. You can see that housing is starred here, schooling, employment, jobs. That's a really important component of what's happening in healthcare. And now some ECOs are actually paying for vocational counselors and housing navigators to help patients get engaged in and have access to the training and skills they need to become employed in the future, or to get connected with housing services that are in the community already. And transportation, and a phone, and clothing, food. I mean, these are big issues for anyone to deal with, much less someone who's just being discharged from a hospital with none of these resources in place. And then a follow-up home visit can really elicit even a greater understanding of what's going on with the patient, and begin to engage them in new ways, and really bring out some of the stories and connections that will help you to figure out, together as a team, what will motivate this patient to engage better in their care, and what are the community resources they have in place, and how can we train those patients, and then also how can we help them learn how to handle all these medications. This is one patient's medication bottles. It'd be complicated for anyone to figure out how to manage that, much less someone who may have low health literacy or may not even be able to read, to know which bottle is which and which one do I take at what time. This is an important part, so you can bring in a pharmacist who can maybe review the medications that collectively come up with a simpler management tool, and figure out a way to make it clear to the patient what medications they should take when, that doesn't require being able to read. And then we want to accompany them to appointments, because there's a lot of information that happens there that is missed on both sides. The patient may not feel comfortable telling the provider that they're dealing with housing issues, or that they're about to have their electricity cut off, or that they don't know where their next meal is coming from. And so as a member of the care team there with them, you can make sure that those important elements are there, so when the provider prescribes something that you know that patient won't be able to adhere to, you can then think together about other strategies for interventions. And similarly, you can make sure that the patient has fully understood what the provider has said, because it's a two-way street, this communication. And then also make sure that family caregivers as well as others are brought into the picture, and even make sure they actually get to their appointment. Because they can have a lot of appointments. This is the full picture of what one patient in Camden has to do in terms of managing their care. And if you don't know how to use a calendar and keep track of any of these appointments, that'd be hard for any one of us in this room to really make sure that you've been to all these places that you needed to go, and know where and when and how to get there, particularly if you don't have a bus pass, or if it's difficult for you to walk. You can really help patients by navigating them through this complex system. And then, as we've learned throughout the day, it's all about partnerships. No one organization can do this alone. You really need a whole team, and these are some of the partners in Camden Coalition that they work with to provide a whole new level of resources for patients. And it's connecting with Meals on Wheels, or housing services, or behavioral health resources. And what's nice about this program, and I think we heard this mentioned earlier today, is that they now are all functioning and able to accomplish even more, because they're now coordinated in what they're doing versus fragmented partners in the care delivery system. And then it's important to track the outcomes of, not only to be able to document what has happened collectively and how you've been able to lower cost of care for these patients, but to make sure they actually did show up to appointments as needed or have got the housing and social support networks in place. And they've engaged in motivational interviewing so that they now feel empowered to do what they need to do, and that you've figured out what their goals are and how you can support them. And then finally, ultimately, you want to graduate them, because it's not sustainable to be able to provide this level of engagement to all the patients in your community. You want to provide them with the tools and resources to be able to go out and care for themselves on their own and make the connections so that if there are further issues, that they know who to call and they know what they're entitled to and eligible for. And in our student learning collaborative, this is one of actually the hardest parts the students engaged in, was like graduating their patients. They felt like they were abandoning them. And so that's an important component of training the students on how this process works and how that they are, and give them the tools to enable the patients to take care of themselves in collaboration with their community. And so this is what we've come together as the partners to do, is we really wanted to provide medical students, pharmacy students, social workers, a whole host of health professions with an opportunity to train together, because interprofessional education is an important component of a sustainable healthcare future. People need to know how to work together and the value of the other team members. Sometimes it's not going to be the physician that has the answer. It's going to be the social worker or a community health worker or a pharmacist. And to get students training together so they can recognize the value and contribution of their other partners is so essential to what this project is all about. And to really demonstrate the value of hotspotting, we want to give them the tools and resources and training to be able to show the leaders at their medical school, at the hospitals where they practice, that this is an effective way to lower cost of care and improve quality of care for your patients. And then, as I think partly why I suspect this award was given, is that we're not just training them on how to do it, but we're training them how to be leaders and champions in their community. And I had the privilege of hearing one of the students speak at the AAMC's recent leadership Learn, Serve, Lead meeting. And she talked about how as a fourth-year medical student, she got this unique chance to participate in the learning collaborative, know that you can't just discharge a patient from a hospital and expect that their care is going to work out, and that that's okay to leave them that way. So now in her first year residency program, which she selected because she knew they supported this type of care, so it makes you attractive if you're looking to recruit and retain medical students and residents. I think that's an important component of the sustainability of this model too, is that it becomes attractive to people that you want to bring into your practice. And so now she was talking about rounding in the hospital and a patient who came in with congestive heart failure. And instead of just prescribing medications and giving the care plan that everyone in that room knew the patient was probably unlikely to be able to adhere to, she was able to then connect that patient with housing and a social worker and a pharmacist to review medications and come up with a better care plan for her, something that might not have happened to her at all and might have left her even further disengaged from the profession that she had spent so much time training in. So now she's reshaping the residency program where she's at, and then all the people that she's training with are going to become different providers as well because of her participation in this collaborative. So it's just so exciting to hear about it. And as I mentioned before, it's a chance for these partners, the three of the AAMC, Primary Care Progress, and the Camden Coalition, to work together and accomplish even more than any one of us could do on our own. Because we've heard that some of these things are kind of risky, and so what the AAMC brings into the picture is the imprimatur that it's okay. This is safe to do, important to do, and a respected activity. And so there's a whole host of value that can be brought in by different partners that you can work with. And what we're doing is providing a 6-month learning collaborative for the participants, and to give them a little bit of funding support. The first go-round, we just gave them $700, which was hardly any money at all, but we got a tremendous amount of applications. And we also provide in-depth training. So we give them school skills and training on how to do motivational interviewing, trauma-informed care, which is huge for this population who's probably had, been subject to violence or other trauma starting from an early age. And then really important is to provide the team building, communication, leadership training, and advocacy training, and that's a lot of what Primary Care Progress brings to the picture. That's their whole modus operandi, is to really get people engaged in reshaping and redesigning healthcare. And so in our second round of the cohort, we actually spent we had a kickoff meeting, and we spent the full day on team building and leadership and advocacy. And the students actually were a little frustrated by this because they wanted to get into hotspotting and learn about how you can get engaged and what their next steps were once they got back to their schools. But we know that they won't be as successful if they really don't know how to partner together. So I think that in the evaluations it'll be interesting to see if they agree that that one-day training was the right level. And what we want to do is continue to learn from them and evolve the program as we go along. And they also get to participate in monthly case conferences where they present the patients to the leadership of the coalition and get the expert feedback on what really should be provided to the teams, the patients. So they're not going it alone. And so these are the 20 student teams that we have. And what's even better is there, in a couple of instances, we have 2 schools in a community partnering together, in the case of LSU and Tulane, and Duke and UNC. And so these kinds of partnerships are taking the whole fragmented healthcare system and integrating them in ways that we weren't even expecting as a part of this project. So it's really kind of exciting. And they're partnering with the schools of pharmacy and the School of Nursing. And you can see that we have over 100 students, but they represent a diverse mix of health professions. And these are the backgrounds of the students who are participating in this current cohort of 20 schools. And most of them on the left have a team that involves some combination of medicine, nursing, pharmacy, social work, public health. And then on the right, they may bring, some of the teams might have brought in someone from the business school who can help them really make the business case effectively, or be an epidemiologist who can help them with identifying their high-cost population. So we really encourage and welcome the more diversity of the students engaged in their team, the better. We didn't want just physicians partnering together. That was a non-starter on our applications. And so the students, what they have to do is figure out how to make time in their schedule to participate in this collaborative. And that can be really tricky when you're dealing with someone from the School of Nursing who is on a different schedule, and even for their lunch hour or the start of their curriculum. And they have to make and engage in this effort and work as a team and commit to spending 3 to 5 hours where they get to know patients and really talk to them and find out what will get them working together as a team. And so then at the end, they want to be able to provide a story that they can take back to their leadership. This is them presenting their cases at our wrap-up meeting of the first cohort, and talk about the patient and show that they've unearthed all the social determinants of health and come up with ways to address them. And describe their interventions, which can be like helping to find a companion dog for a patient, or realizing with the one end-stage renal disease patient who was at risk of being kicked out of all the dialysis clinics in the community, how to calm herself. And they realized through motivational interviewing that she really enjoyed art. So a sketch pad and a book of pencils is probably the difference between her being kicked out of the dialysis and excluded from all of her ability to seek care. So it's not a huge intervention, but it's just an incredibly important and powerful one. And then finally, to be able to show a before and after. I know it's hard to see, but this shows the utilization on the left of the number of visits and repeat visits that this patient had prior to the intervention. And then you can see that the line becomes flat with a tiny blip up at the end after post-intervention. So, and an important component is also having an advisory council with us. So the students now are giving us guidance on how to take this to the next level and look for new partners and new structures that we can expand and train the faculty to become the next leader of the generation of hotspotters and to become the future of health equity, which is what I think we're all here about and excited to talk about today.